So while the slides are booting up, I just wanted to introduce this topic of machine learning with a little bit of context. So when we think about investments, right, we know that according to CMS, we spend approximately $3 trillion every year on healthcare. And of that $3 trillion, it's estimated that about 16% is devoted to critical care, delivery of critical care. So we're spending something on the order of $550 billion a year in this country on critical care services. And the question is, are we making a good investment, right? Can I have my slides, if it's possible? And I hope we are. I think the answer to that question is probably yes and no. We've made significant strides, a lot of advances, important changes have occurred in the field of intensive care medicine, but I think it's also clear that there's a lot more that needs to be done. We know that the long-term outcomes of critical care survivors are often abysmal. And so I'm hoping that we can potentially think of a path forward in terms of developing new perspectives on how to improve the outcomes of our patients in the ICU. So this talk is going to be devoted to machine learning, but I think more broadly it's going to be about data science. And I think there's little doubt, you've heard from some of the previous talks in this session and also across this meeting, that big data has arrived in medicine. And it's no secret for anybody. I don't need to convince you. One of the drivers of this phenomenon is clearly the increasing efficiency and power of computing and the decreasing cost. So everybody's familiar with the Moore's law, right? Which estimates that the power of a processor will essentially double every 2 years. And although that rate of rise or rate of increase is beginning to slow down a bit, there is evidence that that's probably one of the driving forces behind the data revolution. Certainly another source of this explosion of big data and the arrival of big data science in medicine is the fact that we have access to unprecedented amounts of information. And one way to demonstrate this paradigm shift is the cost of sequencing DNA. You recall that perhaps in the early 2000s, it cost about $10 million to sequence the DNA. It now costs maybe $100 or $200. So that exponential decrease in the cost is obviously very important. If you look at this graph, it's kind of interesting to see that we're currently in an age where it costs less to sequence your genome than it costs to perform a phenotype, meaning, for example, just to admit a patient to the hospital, do a history and physical, get a chest x-ray, EKG, get some labs. That's going to cost way more than sequencing your DNA, and we need to ask ourselves, where is the value? So we certainly have access to big data, and we have access to big data at so many different levels, going from, of course, the cellular, the genome, all the way to the information that we can extract from electronic health records, and then also population-based epidemiologic data, data on exposures. And this wealth of data is obviously both an opportunity and a challenge. The paradigm of precision medicine to which this session is devoted is really about how to leverage big data for the purposes of improving both biomedical science and also clinical care. And that's illustrated in this diagram here. We, I think, have developed over the years a very interesting concept where using big data, which can be the omics data that Dr. Faden spoke about, it can be the EHR data that Dr. Harasovich spoke about, it can be data from imaging, different types of imaging. We use our increasing sophistication in information theory and artificial intelligence to really generate quantitative predictions on biological systems and on human health. And using this information, we hopefully can arrive at more effective and reliable methods to personalize the care that we deliver. But the big question is, how do we get from here to there, or from there to here, right? So we have all this data that is now accessible, cheap, and our goal really is or the output, we hope, is going to be personalized precision medicine, where we can tailor therapies based on the specific biological features of every patient considered as a unique entity. And I would argue that the way to achieve this is going to have to involve some degree of machine intelligence. So we're talking about a progression, right? We start with data, raw, unprocessed data, we hopefully can generate, with increasing levels of organization, we can generate knowledge. And using this knowledge, we can generate predictions or insights. And then using that insight, we can make interventions and hopefully have an impact on outcomes. So why machine learning? Machine learning is also here with us today. We can see it every single day in our working and personal lives. There are cars that can drive themselves, and there are computer algorithms that can outperform even the best players in highly sophisticated games like Go. And so when we talk about machine learning, artificial intelligence, I think we're really talking about a hierarchy of related terms. So artificial intelligence relates globally to all systems which simulate human behaviors, in particular the capacity to learn. Machine learning really has to do with computer algorithms which use statistical techniques to iteratively improve their task performance. And deep learning is a little bit different. It's a subset of machine learning in which algorithms learn representations of data that are increasingly abstract and use this to generate outputs that are increasingly precise. So I'm going to walk you through very briefly some of the basic concepts of machine learning. So machine learning is often classified as being either supervised or unsupervised. And we'll talk about what the difference between these two types of machine learning is. One of the most common types of supervised machine learning is just simply regression. And then there's also classification. Unsupervised machine learning has to do with clustering or dimensionality reduction. And then there's this reinforcement learning that we're not going to talk about today. So what is supervised machine learning? It's really quite simple. You have a set of variables, which we call features. You have labels, which are essentially the presence, for example, or absence of a disease, or the presence or absence of a specific outcome. And then you have a classifier, which can be either a simple statistical algorithm, or it can be a machine learning algorithm. And what you do is essentially you train your classifier using data to develop an association between the features and the desired output. Ultimately, what you want is a prediction. You want to be able to predict, for example, whether or not a patient is going to have a complicated course in the ICU, whether that patient is going to die, whether that patient is going to have a good or a favorable outcome after the ICU. So these are the most important outputs for machine learning in healthcare. And this slide essentially illustrates the process. You're going to start with a data set. Typically what happens is the data set is split into a so-called training validation data set, and then you have a test data set. So you train your classifier using the training and validation data sets, and then you subsequently determine its accuracy using a test data set. And so the output is essentially of your model is going to be a prediction, for example, survival in the ICU. And you're going to determine the performance characteristics of your model using different methodologies. One of the most common ones, that we'll talk about today, is the discrimination of your model, meaning how well does it discriminate between classes of outcomes. And that's often represented as an area under the receiver operating characteristic curve. Unsupervised learning is quite different. Here we're talking about exploring a data set that is complicated, that is high dimensional, but without any a priori labels, right? So we don't really know what we're looking for. We just want to understand whether there's some latent information in this data set that can help us potentially to make some inferences on the underlying disease or the treatment process, right? So there's no labels in the unsupervised paradigm, but it can be a very, very important initial step to generate some ideas that can then inform a supervised approach. So these are some examples of unsupervised machine learning. As I said, the most common one is clustering. Another very important example of unsupervised machine learning is dimension reduction. And this is highly relevant to when you have these very high-resolution data sets. You need to reduce the number of dimensions to make it tractable statistically. People talk a lot about deep learning, and deep learning is, as I mentioned earlier, a subset of machine learning, where essentially you construct a neural network that is going to have inputs, it's going to have outputs, and then you have a bunch of layers that are interconnected. And these layers are constantly being informed by weights that tell the different nodes in your network whether the output is close to the expected So here's what you have, for example. You have a specific input. That input is being adjusted according to specific predefined weights. And then you define an output. The defined output is going to be probably a little bit different from your desired or your target output. And so that is expressed as a loss function, which is then back propagated into your network to further change those weights that have been assigned on the individual nodes. This is my best understanding. I'm not a data scientist. But anyway, so this is the basic concept of back propagation, and this is really the sort of basic mechanism that is driving deep learning algorithms. Now, why are people interested in deep learning or neural networks? They're interested in because it seems like there's no limit to the accuracy of prediction, right? So with conventional, machine learning algorithms, as you input more data, you're going to reach a sort of plateau beyond which the accuracy or the performance of your model is no longer going to increase. On the other hand, with deep learning, the argument says, theoretically, you can keep giving it more and more data, and the model gets better and better and better. Now, whether that's true or not, I don't know. One of the issues with deep learning is the question that we referred to earlier of interpretability, right? So a lot of machine learning is in a way opaque. We're dealing with a black box. We throw features at an algorithm, and we ask it to generate an output, and we're happy if that output is close to what we expected. But we really don't know what is happening under the hood. And the problem is even exacerbated with deep learning. So on this graph, you can see on the y-axis, you have the interpretability or the transparency of your model. So how well can you understand it? And then on the x-axis, you have the complexity of the model. So you can see all the way on the right, the most complex models, the highest performing models apparently are neural networks or deep learning. But those are also the most opaque. Those are the ones that we understand least. Even if you talk to the world's specialists, the people who have actually invented deep learning, and you ask them, how does it actually work? They will have trouble explaining it to you. So it's no secret to many of you that deep learning, machine learning has arrived in medical research. I'm giving you here some examples of classification tasks published in major journals, for example, for identifying, using a deep learning algorithm, diabetic retinopathy, or identifying arrhythmias on a EKG, or identifying skin lesions using photographs in a dermatological database. This is an example of a recent paper looking at classification of 12 lead EKGs. And what you can see here is that this is the ROC curve. In blue is the neural network model, the accuracy of that model, or the discrimination of that model. And this point here, this green, is a point estimate of a cardiologist that were also sampled. The gold standard of this model was a panel of board-certified cardiologists. This is a test set of cardiologists. And you can see that the model, in general, at least for detection of atrial fibrillation, outperformed the average cardiologist enrolled in this particular study. This is another example of deep learning using the photographs of children with genetic dysmorphic syndromes. You can actually work your way using a convolutional neural network to identify the specific genetic disorder that they have. And this has been shown with single genetic disorders. This is a more recent paper with a panel of genetic disorders by training the classifier to recognize the association between specific faces, photographs of faces of children with these disorders, and associate them with specific genetic disorders. They actually generated a high degree of accuracy. So why are we talking about this with regards to the ICU? We're talking about it with regards to the ICU because in many ways, I would like to make the case that the intensive care medicine is a perfect laboratory for machine learning, right? So the reason is because we have multiple simultaneous data streams. We have very rapid disease onset and progression. Our patients are incredibly heterogeneous. There's a very compressed time scale for making decisions, as we all know. We're all constantly multitasking. And there's high levels of uncertainty, especially in the onset of critical illness when we first receive a patient in the ICU, transferred from the floor, transferred from the ED. We don't even know what their name is. They're unconscious. A lot of things are going on. How do we deal with all these problems in the ICU? And I would suspect that data science is going to provide some level of response to that. Okay, what just happened? So some of the values of data science in the ICU include, as we discussed with Dr. Faden, the elucidation of pathobiological mechanisms, recognizing patterns. decision support, as discussed by Dr. Harasovich, resource allocation. I would argue that perhaps the most important task for data science is the task of prediction. So predicting the presence of a disease, the time of its onset, the severity, the duration, whether the outcomes are going to be good in the short or in the long term, and perhaps most importantly, response to therapies. I'm going to give you a few examples of how we can do this. This is a paper from a group in Hopkins where they looked at a set of features, very simple things like bicarbonate, systolic blood pressure, Glasgow Coma Scale. All of these were extracted from the electronic medical record, and this was the MIMIC-3 or MIMIC-2 database. They used a machine learning algorithm to create a risk score that predicted the onset of septic shock. And the interesting thing is that using this risk score, they were able to predict septic shock onset approximately 18 hours before it was recognized clinically, right? So this was done retrospectively. But it's very interesting that potentially the use of this kind of scoring system could offer windows of opportunity for clinicians to treat patients with early signs that are clinically not recognizable. In fact, the TREWS score has now been implemented across the Johns Hopkins ICUs as an early warning system. Everybody in our institution is being trained on the use of this system. This is another very interesting paper looking at the prediction of intraoperative hypoxia. They used using a series of features extracted from the time series of physiology in the operating room and also combining that with demographic features. They had a real-time decision support system or real-time machine learning algorithm, deep learning algorithm, that gave essentially a probability of hypoxia occurring in the next 5 minutes. And this prediction system actually worked quite well. It outperformed. Here you can see in purple is the machine learning algorithm. In blue is the combination of the anesthesiologist working with the machine learning algorithm. And in green is the anesthesiologist alone. So you can see that this deep learning algorithm actually did a better job of predicting short-term events like hypoxia in the operating room using just a discrete set of physiologic time series and demographic features obtained from the record. My group has been very interested in prediction of neurological outcomes in patients who have cardiac arrest, and we've been using a number of different modalities. Some of our recent research has been devoted to both structural and functional indices of connectivity using MRI, and we've been able to do this, especially the processing portion has been accomplished using support vector machine, for example, which is a machine learning algorithm. And I don't really have time to talk about this work, but I wanted to talk about some more recent work that we've been involved in, which is a collaboration between researchers in the Department of Anesthesiology and also computational experts. I've shown here some of our colleagues in biomedical engineering at Johns Hopkins. And essentially what we've done is we've extracted data from a very large database called EICU. This is owned by Philips, 220,000 patients. And we extracted both electronic health records data and physiologic time series data in the ICU. We narrowed it down to those patients who had had a cardiac arrest. And we developed a model to predict both neurological outcome and mortality. And on the right here, you can see the different machine learning algorithms that we used to see if we could classify patients into outcome categories based on these features. So one of the sort of underlying hypotheses in this work is that if you use data that's being captured once every hour or maybe even every 10 minutes, you might actually not capture the events that are very punctual, that occur, for example, over the course of a few seconds. A patient may become hypotensive and that gets rapidly corrected. Maybe over the course of 30 seconds, 1 minute, 2 minutes. If your data collection interval or sampling interval is every hour, you're obviously going to miss that. So our hypothesis, one of our hypotheses was that we need to get the minute-to-minute sampling involved or included or integrated into our model. So we had 200,000 patients. We ended up with 2,000 with cardiac arrest. These are the features that we identified. So we had the time series features. We had numerical features, for example, blood gases, and then we had the categorical features, such as whether or not the patient was intubated, the location of the cardiac arrest, gender, age, and so forth. And the outcomes that I mentioned, those are the labels. So in brief, you can see here the results of our model. So when we look at the AUC, if we compare using the Apache score, which is given here in green, which is the gold standard for prediction of outcomes in the ICU. So if we look at the Apache score, we had an AUC of 0.74. When we integrated additional data from the electronic health records, we had 0.83. When we looked exclusively at the physiologic time series data collected in the first 24 hours in the ICU, we didn't have a significant difference in prediction accuracy. However, when we combined in our model the EHR data and the physiologic time series, we actually obtained an AUC that was a bit better. It was 0.87, so 87% of the time, the model correctly classified patients into neurological outcome categories. And then when we compare different models, just to make things very brief, here is the Apache score. This is a neural network. This is a random forest. This is a generalized linear model. This is a gradient boost model. And this is an ensemble model. The ensemble model actually combines inputs from multiple different machine learning algorithms. The best performance, not surprisingly, was obtained with the ensemble model that combined also the data from the EHR and the data from the physiologic time series. And then this touches upon that question of discovery of features or interpretability. So we tried our best to identify what are the features that were most highly predictive of outcome in this model. And the ones that came out are listed here, and a better way to show this is here. And many of them are derived from the Apache. So there's the GCS on admission, the worst motor GCS, the worst eye GCS, the lowest temperature, the SOFA score, the worst verbal GCS, mean lactate. So these are things that are not surprising. Interestingly, there's this one here as well, dexmedetomidine, Precedex, seem to have a positive correlation with good outcome. So I'm not quite sure what to make of this. This is, again, something that was generated by this machine learning model, perhaps something that could be explored. I don't know if it's biologically significant or not, but it was an interesting and surprising finding. The others were quite interpretable. We have some other ongoing projects. This is a project where we're using accelerometers that are placed on patients in the ICU to measure their motor activity and using that as a potential feature to predict outcomes in the neuro ICU. And then we also have this very interesting study where we're looking at the CT characteristics of patients with ischemic stroke. We're using each of the voxels in the CT as a feature in a machine learning model and using that to help predict whether or not there is a stroke in the hyperacute phase when CTs are normally read as being normal. Our hypothesis is that there are subtle changes in density that can be detected using, again, a segmentation approach to the CT scan combined with a machine learning algorithm. So in summary, I hope I've been able to show you that data science is poised to transform care in the ICU. I think data science will help to derive biologically driven classification that can optimize the design of clinical trials. It can also help us to select patients for treatments and to determine the efficacy of those treatments. We're hoping that use of data science is going to help us, like we've shown today, build better prediction models. And we're hoping as well that it'll generate some insights on biological basis of critical illness. So I'll stop there, and I think we're running a bit short in time, but I'm happy to take maybe one question. Yes, sir.
My name is Mike Schnessen from the University of Pittsburgh. I wanted to ask you about this idea of maybe discovery of understanding what's behind the prediction. Do you have a sense of all the predictive things that are being developed, how many are actually actionable? Because even with the list that you shared, and said these are the ranked features, maybe a lot of those still aren't actionable. And does that, marginalize the prediction that you're making?
Right, and I think you're touching upon a really important point. I mean, there's a degree to which some of this could look like an intellectual exercise without any sort of real deliverable. I think the key, and this is the hard bit actually, is to build models that can help predict response to specific therapeutic interventions. There's a very nice paper that was published a few months ago in Nature Medicine where they looked at the impact of specific interventions like fluid challenge or giving a diuretic, and how clinicians in the ICU often either under or overestimate the expected benefit of that intervention when compared to a validation data set. So I think where this field needs to go is beyond simply predicting events and towards predicting the impact of interventions. And the way that we can achieve that is by integrating in our models the specific interventions that we're talking about. If you noticed, all of the studies that I showed you, none of them actually integrated things like blood transfusion, mechanical ventilation, renal replacement therapy, antibiotics, all these things that we do every single day that are probably having a major impact on outcomes. They're not integrated in the models. They're very hard to actually extract from the EHR and integrate effectively into models. But I think that's where this needs to go. Okay, just one more, and then it's going to be the last. Yes, go ahead, Raquel.
Can you talk about what the best outcome we should be using in these prediction models? Because one of the things we've learned at our own institution is half of our patients are actively withdrawn on, which means the clinician may end up affecting that outcome if they were someone who withdraws early versus those who tend to try to push families in a certain direction.
So I'm so glad you asked that question. We were struggling with exactly the same. It's clear that especially in cardiac arrest, there's a significant proportion of patients where care is withdrawn. We were not able, using the natural language processing algorithm and applying it to the clinician notes, we were not able to find anything that looked understandable. But we applied another algorithm, and I didn't show this data, but where we had 3 domain experts, myself and 2 of my colleague intensivists, rated a total of 2,000 essentially transcripts that were taken from the last 2 hours of a patient's life in the ICU in this data set. And looking at the trends in those waveforms, we were able to essentially classify. We classified based on our knowledge, right? So we said, if you saw all of the physiology going down simultaneously, we said, okay, this looks like withdrawal because there was no intervention. And so we did that, and then essentially my students now are working on integrating that information as an additional feature in the model. So I think it's really important. In the future, I think clinical trials are going to have to integrate withdrawal of care information as they do not do correctly nowadays.